I don't want to start a stampede or anything. We have cured interstitial cystitis in some patients.
I had the privilege of chatting with Dr. Stephen Smith, a retired interventional radiologist who made a discovery in his career treating women with pelvic congestion syndrome, also known as pelvic venous insufficiency. Hello!
Well, hello there.
Thank you very much for your time in advance.
Nice to finally see you in person-ish. How are you today?
I, touch wood, am really, really good. I'm on a regime at the moment, and although my progress has been somewhat uneven, it's definitely on an up. So I'm on antivirals, antibiotics, and an immune system modulator, and some herbal treatments under Professor Jacques Lambert.
I saw your session with him, and so I learned about him.
It has been rocky, and there are certain antibiotics that I'm on that have affected some of the other things that I'm trying to address, because as we know, ME is this monster with a systemic nature. Unfortunately, some of the things I've used for autonomic support through Dr. Peter Rowe, such as ivabradine, it was reduced by one of the antibiotics called rifampicin, so I've just swapped that over to a beta blocker, which, fingers crossed, I'm doing okay on. So there's, I'm having to play around with it, but overall, the fatigue is improving. The post-exertional malaise, which is a key feature in ME, obviously, is reduced. Not non-existent, of course, but the pelvic pain, unfortunately, and the interstitial cystitis, both of which I did think were getting better, are most definitely not. And it really has, I suppose, spurred me on to do more investigation into pelvic venous congestion. And I'm very, as you know, very, very interested in your work, because you've got data that shows the overlaps, I think more so with the POTS and orthostatic intolerance, but then obviously ME bleeds into that. Before we dive into everything else, I want to very quickly mention something that might help someone else out there: hypoparathyroidism. Dr. Jacques Lambert picked up on my low calcium, and he told my GP to further investigate. That's when we found my serum parathyroid hormone was consistently low. Turns out my iron and magnesium were also on the lower side. Given my long-standing issues, chronic rhinitis and candida, I did a bit of digging myself and suggested we also test for autoimmune polyendocrine syndrome type 1. That'll go alongside a neck scan and some more blood work they've already planned. It's a lot to take in, but honestly, I'm okay. Infectious diseases professors like Jacques Lambert give me hope. And sure, maybe what I really need is a wizard to give my immune system, some talking therapy. That's a joke, obviously. If you know, you know. If you don't know, thank God you escaped it. Anyway, BMJ, sort yourself out. Moving swiftly on to real research and real science.
I am an interventional radiologist. I'm retired now, but I've been just trying to finish up this research. My practice was kind of a referral place for women who had, pelvic pain, sex pain, kind of orthostatic pelvic pain, pain in the vagina, pain during sex, caused by enlarged veins in the pelvis or stretched out veins. Varicose means worm-like, and these veins were often inside, so gynecologists couldn't see them, or if they saw them, dismiss them. It turns out that condition causing pelvic pain with pelvic veins that are insufficient, meaning that blood doesn't keep going the correct direction through them, rather it may stagnate in dilated veins or be blocked from ascending in the upright position back to the heart where it should go. As an aside, I'll say that the blood flow direction in all veins should be towards the heart. So it would turn out that women would have pelvic pain from these veins, and the gynecologist would chalk it up to endometriosis. So a lot of the women who have this have multiple endometriosis surgeries or laparoscopies, and they don't get better. We know that the veins can account for, I'd say, 40% of chronic pelvic pain in women, and yet if you look at the Royal College of Surgeons, the American College of Obstetrics and Gynecology, see their recommendations, they don't even mention veins. I think that people shouldn't oppose an idea. You mentioned at least 3 conditions that, as you know, are all associated with each other. Patients with interstitial cystitis, ME, CFS, several other conditions, they're all associated frequently in the same patient. Interstitial cystitis, even irritable bowel syndrome, okay?
Yeah,
And
absolutely.
fibromyalgia
And
and
as
migraine.
well. Ehlers-Danlos Syndrome as well.
Yes, of course.
Ehlers-Danlos syndromes, EDS, are a group of inherited disorders that affect connective tissues, primarily skin, joints, and blood vessels. These conditions are caused by variations in genes that affect structure and function of collagen, a protein that provides support and elasticity to the body. Symptoms vary on the specific type of EDS, but often include overly flexible joints, stretchy skin, and easy bruising.
We kind of discovered, I think we did, that Ehlers-Danlos syndrome, or loose joints, hypermobility of joints, was associated with pelvic congestion syndrome or pelvic venous pain, these abnormal stretched out veins. Here's how I figured this out, that this stuff went together. I had a patient come back to me after we had fixed her veins, with a stent, and then did some embolization. This is all non-surgical, and this patient gets sedated. A little tiny catheter goes through a skin nick, and you can steer it around anywhere. There are no nerves inside. You can't really feel anything. And so you can travel anywhere. You can go to the brain, you can go to the right arm, left leg, pelvis, anywhere, by steering this little thing around. Okay, great. So once we get to where there's a problem, say it's a bunch of varicose veins, we can inject stuff through the little catheter, which is delivered right where the veins are, and sort of fill them up, and then they shrink up and go away. If you think of those big veins in the pelvis, we're talking huge, as being a place where blood flow stagnates. Blood is supposed to be going upwards and creating normal pressure in your heart and veins and your brain even, okay? It turns out that in patients with ME, they have low blood flow in their veins, and that's been known for quite a while. And the research of Dr. Rowe, Dr. Van Camp, and Ocon, a lot of investigators have noted that people stand up and they ain't got enough blood flow to their brain. We used to be quadrupeds and we evolved to stand up. And when you stand up, the highest part of where blood has to go is your brain, right? Your head. So it wouldn't work very well if we stood up and then we couldn't get blood flow to our brain. We would just collapse and be eaten. But we evolved a way to get blood up to our brain. Veins aren't like arteries. They're very thin-walled. And the way blood goes up is when your muscles contract. Even when you breathe, veins get squeezed and they have little one-way valves. So like a ratchet, blood moves back up. And when it gets near your heart, it just sort of goes into the pump and it's pumped around again. Well, there are a lot of people like you who have trouble standing up. They stand up and it's normal for blood pressure to sag down a little bit, and then, your homeostatic mechanisms take over and they boost your blood pressure a little, your heart increases a few beats per minute or something. Various things happen. But what if your veins, especially the big veins inside, the big pipes were blocked, or there was a big bunch of stretched out, goofy veins because the collagen in the walls of the veins was bad, stretchy, Ehlers-Danlos type collagen? What if everything bagged out, even maybe the skin in your legs and the veins in your legs? And so now you stand up and you don't get that boost up to your brain or heart. If you have a big, successful attempt at an emergency accommodation, your blood pressure might stay the same, your heart rate might go up a lot, and if it went up enough, you would have this sort of emergency reaction, sweating, anxiety. You just feel terrible because you've gone to emergency power. Your adrenal glands kick on, your sympathetic nervous system tries to pump out vasoconstriction, it tries to tighten up the whole vascular system bag to make it push stuff up, because obviously, like I say, you've got to have the ability to do that in an emergency or you'll die.
People with ME often describe it as a living death. It sounds like hyperbole until you're in it. During a crash, the brain is starved of oxygen. Thought, movement, even light, touch, sound become unbearable. This can last weeks, months, years, and there's no guarantee you'll come back.
Like many teenagers, Millie McCain enjoyed miming on TikTok and taking selfies on her phone. That was before she was hospitalized, needing to be fed through a tube. Diagnosed privately with severe ME, she's now spent 10 weeks in hospital.
And I always say it's like in Vietnam, if you've been the movie Platoon or something, you've been shot and you're trying to make it to the chopper. It's an emergency. You've lost blood. Your body can go into an emergency situation where a lot of things happen in a certain way. You can make it to the chopper. But what if you were trying to make it to the chopper all the time? And I try to make sense out of all of this stuff in regard to ME. And here's one way that I think of it, and Peter Rowe thinks of it in the same way. In fact, he has a study that shows this. If this all happens and you don't get a big effective response, you won't get POTS syndrome, you'll get chronic fatigue.
Imagine you're trying to reach the rescue chopper, your only chance of survival, and instead of helping you get there, the hospital throws obstacles in your path. This is what it can feel like for someone, especially with the severe ME, and the very place that's meant to offer you care can end up making you worse. While NICE issued updated guidelines in 2021 for diagnosing and managing ME/CFS, including specific recommendations for hospital care, these are not consistently implemented across NHS hospitals. There is still no standardized NHS protocol to ensure they are applied in practice. You can hear the desperation in my voice. This absence of a unified approach has led to inconsistent care, abuse for many patients with ME, inadequate treatment, and in some tragic cases, avoidable deaths.
A coroner has concluded a young woman who from Devon died from natural causes because of severe ME. Maeve Boothby O'Neill had been suffering from fatigue since she was 13. By the time she died, aged 27, she was unable to chew food or sit up. Today, the coroner said it is not possible to say if any treatment could have halted her decline, but she hoped lessons will be learned in the hope future deaths can be prevented. Here's our health correspondent, Jen Smith.
This is just some of the paperwork Sarah has had to get to grips with during the inquest into her daughter's death. It's been a complicated hearing that's taken 3 years to get to this point. The inquest has been widely reported as headlines around a lack of understanding and treatment of ME have made national news. So will this be the catalyst for change that many are hoping for?
They now understand what they should have done and that they've written a plan for what they should have done. They've got standard operating procedures for what should be done. What I'm less hopeful about is that that will become widely known.
For a young woman from a loving family in Devon to die of dehydration and malnutrition in this day and age is difficult to comprehend. Put simply, the inquest heard no one knew how best to treat Maeve. And there are other families in Devon, like Maeve's, terrified of what might happen to their loved one with severe ME.
As someone living with ME, even at the milder end, my justified fear remains. Going into hospital for help is highly likely to make me worse. And in my pursuit to try to improve my quality of life, I can only share what I'm doing in hope to help others.
We know that people, even in POTS syndrome, people they have decreased blood flow to their brain. They can do transcranial Doppler. They can look at blood flow into the brainstem. I started noticing some things in my pelvic patients. So patients would come to me, oh, it hurts when I have sex, and it hurts if I stand up. My pelvis, my vagina aches, or aches on the left side of my pelvis. It's terrible, and nobody can help me, Dr. Smith. So I was okay. So we would look for the veins, and then we would fix them just with these, a stent or embolize the veins, and then they would come back. The first thing that I noticed was that a patient said to me that her pelvic pain was gone, but her interstitial cystitis that she'd had for many years was gone. And then I realized patients were actually concealing some of their symptoms from me. They had gotten used to not wanting to tell all the doctors about all their different problems because it makes them sound crazy. Oh, okay. Well, so I remember saying to her, you didn't tell me that. It's not in here. And I know that, we go through a checklist of all the systems. She goes, well, I'm here for just this problem, my pelvic vein pain and sex pain. Well, turns out she also had POTS syndrome, and that got better. And so that set me off. I thought to myself, well, I read about those two things. Were those two things related, POTS syndrome and interstitial cystitis? They were. I thought, what other conditions or symptoms are those two things also related to? And I read a lot, and I ended up figuring out that irritable bowel syndrome, migraines, POTS syndrome, ME/CFS, interstitial cystitis, even excessive sweating, anxiety attacks, a lot of stuff occurred and overlapped in a lot of patients, 50%, 70%. Does it make sense? Coincidentally, these people have, 5 different coincidental unknown causes for all these different things if they're overlapping. It makes more sense if there could be one or a couple of things that could contribute to it. I did several things. One of the things I did was I did an imaging review with Mayo Clinic Scottsdale. We got permission from the Institutional Review Board to do a study where we looked at any CT scans we could find on patients who had POTS syndrome or who had been diagnosed with POTS syndrome. And then we had a control group. And it turned out that the POTS syndrome patients, so let's just say they're dysautonomia patients, right? If we want to lump them in together with your problem. So that they had a 70% incidence of abnormal pelvic veins by measurement. And this was carefully measured. That was the first thing. The next thing is I went to the Pelvic Congestion Syndrome Facebook group, about 8,000 members. So we ended up doing a survey, all the symptoms of all these different things. It turned out these women who had pelvic congestion syndrome had all this other stuff. They fit into this big constellation of symptoms that were orbiting some kind of a black hole that we couldn't see.
I'm just going to interrupt you there.
Go ahead.
I'm struggling to stay sat up, even with my knees up, and I can see I wear this little thing here, so it tells me when my heart's going quite high. So I'm going to lie down and just maneuver myself to be at more of an angle.
Good. You can lie down, do whatever you want. All right. So anyway, the more I read about sort of the core dysautonomias, the more they were involved in blood flow. So it started to make sense. What if we're doing something to improve blood return? And if all these physiologists and neurologists are measuring a deficit in blood return, what if we're improving that sort of unwittingly? In other words, we were trying to decrease elevated vein pressure in the pelvis, which I thought was irritating the bladder and the vagina and all that stuff and causing pain. But what if we actually were freeing up blood flow to go north and supply the heart and brain and make things better? What I did is I made a questionnaire for our patients. I included some sort of canned questionnaires from other specialties so that if another type of doctor could look at it, they could say, oh, okay, I'm familiar with that. People wouldn't just think we were making stuff up. And I put in a bunch of other stuff. One of the things I put in was prolonged recovery from exercise. I put that in. I'm just a stranger in a strange land. I'm
Quick
trying
question.
to read about
So did
this
you
stuff.
put in prolonged recovery to exercise? I've got a note on it here. Did you put that in a bit later, sort of afterwards, once you'd connected the ME?
I did. But we did a follow-up study from 5 centers of 59 different patients, and that all of those patients filled that one out. So one of the things that I noticed was that a lot of the patients were very anxious. They would call the office, just every day, and they would, when can I have this done? But after we did the procedure, they became unanxious. And I started to think, what if their anxiety was caused by adrenaline and cortisol levels because they were living in the make it to the chopper phase emergency called fight or flight. What if we were taking away fight or flight, the emergency response, and they calmed down? And a lot of them got more energy. One of our patients said, no matter what I do, I could sleep 10 hours, 12 hours, and I wake up and I'm still tired and I've got kids and it's driving me crazy. And then she said, oh, now I sleep 5 hours and I signed up for kickboxing at 5 a.m.
When I went through the questionnaire, which I did think was brilliant, by the way, it made me feel very validated seeing some of those sort of questions. So I thought, wow, I get to answer these if I were a patient or someone ticking it off. I did think to myself, I didn't notice unrefreshing sleep. And I did look at the PEM side, post-exertional malaise, and think that if we were to bring ME to that, then yeah, that needs to be studied explicitly and maybe even, well, definitely even more so than the questionnaire does.
It's not perfect, but again, we're outsiders. You know, I'm starting out with people who have weird veins in their pelvis and they have pain in their pelvis. They come to me for that reason. What I'm trying to figure out is sort of make a big omnibus questionnaire that is sort of an assay for all this other weird stuff to see if my patients have the other stuff, number one. But number two, to see if after we fix their veins, any of that other stuff gets better. And boy, it did. We tried to publish it, and it was, I know you talked to Peter Rowe, didn't you?
Yeah, I did. I love
He's
Peter
a
Rowe.
great guy.
Brilliant.
He's a great guy. He wrote a paper in 1998. It got rejected. That's like 20 some years that nobody did any research on this. I mean, it was sort of, even today, I can tell you that I have a lot of trouble getting some of my colleagues internationally to pay attention to this. They sort of, I don't know if there's an attitude of, if this were true, we would have known about it, but we need somebody who is got more money than they know what to do with. I know what we could do to help women, to help you and people like you. Let's see if we could do a real controlled study of this and see if we can figure out which patients will benefit. The procedure itself, it's very, very safe in the right hands. Embolization, stent, whatever. I had some patients come back 20 years after I'd put a stent in their pelvic veins and stents were fine. They're not without risk, but the risk is very low. And compared to the risk of having all of these conditions, I mean, you know better than me. I started looking at these patients, and some of them commit suicide, as you know, partly because they don't think anything is happening. They don't see a cure on the horizon.
Suicide in ME is a response to intolerable suffering, disbelief in some cases, and decades of systemic neglect. With millions more developing long COVID, many of whom meet the criteria for ME, this crisis is expanding. It was never invisible. It's just been ignored.
We made all this progress on the viral and this and that and the other stuff. Well, what is this blood flow stuff? The way I look at it is, if I fix your blood flow, their dysautonomia goes away. They didn't have dysautonomia. Dysautonomia means your nervous system is defective. It's broken, right? And certainly viruses and many other things can affect your nervous system or your nerves or your sympathetic or parasympathetic nerves. Absolutely. But if this can be underlying everything in some people, how can we screen people? How can we decide which patients maybe should get this?
This sort of thing is available, but as you say, it's just not spoken about and it's not being educated.
Here's the problem. If you think of, you're fatigued, you can't get up, you don't think that gynecologists are preventing you from being cured, but gynecologists are the people who own your pelvis, okay? If they are mentally or constitutionally or educationally not going to investigate your pelvic veins, and you do have other problems like interstitial cystitis or pelvic pain or sex pain, and they dismiss it, you're screwed.
Urologists as well, because I was bounced from several different urologists with chronic UTIs that weren't always diagnosed because the tests at the end of the NHS aren't fit for purpose.
Yeah.
But that made me look more into infection and infection persisting in tissues, hence why I'm on the antibiotics I'm on, because they do infiltrate the tissues.
I live with chronic viral and bacterial infections, including recurring urinary tract infections, UTIs, that are complicated by interstitial cystitis and ongoing pelvic pain. Overactive bladder syndrome has also been mentioned in my medical notes, alongside a suppressed immune system. In 2018, an acute hospital-level Epstein-Barr infection hit like a freight train and led me to an ME diagnosis. 7 years into the crash, which made me wonder if infection alone could explain my ongoing disability. But infections don't act in a vacuum. They can trigger immune cascades, like MCAS, releasing enzymes, elasticase, and MMPs that break down connective tissue and may weaken blood vessel walls. This sent me looking for an underlying connective tissue issue. I don't carry a formal Ehlers-Danlos diagnosis, yet several specialists see the signs. Hypermobile hands, a positive Gorlin sign. Yep, I'm one of those people who can touch their tongue with their nose. Enter interventional radiologist Dr. Stephen Smith. His data show that in roughly half of the patients with hypermobility or multiple pregnancies, structural pelvic vein weakness appears to be the upstream domino. Fragile, distensible veins impede blood return, kick the body into perpetual fight or flight, and drive chronic cortisol release, an immune suppressant that could let latent viruses like EBV linger. Importantly, pelvic vein blockage itself isn't thought to be caused by infection. It's most often linked to collagen defects or pregnancy-related stretch. Still, absence of proof isn't proof of absence. Flow problems and infections may amplify each other in a feed-forward loop. Bottom line, some people's symptoms may start with weak veins, others with a viral hit, and many, myself included, may straddle both worlds. The real challenge here is figuring out which domino to target first for each person. My next step is to diagnose or rule out pelvic venous congestion.
First of all, interstitial cystitis, they don't know what it is. The urologist's been in charge for years. They don't know what causes it. After I saw it going away in people who we fixed the veins, I thought the actual venous congestion is probably making blood flow bad in the wall of the bladder. This happens in I don't know if you've ever seen people who have really bad varicose veins and they have like dark spots on their ankles, and the tissue of their ankles can die off and form ulcers, okay? So having high pressure in your veins can make it so the tissue isn't nourished. It's ischemic or short of blood flow. Even if the arteries are delivering blood to the tissue, if venous pressure is high, there's no good capillary flow. Oxygen can't get to tissues. Waste products can't get out. So this makes a kind of a mysterious local malaise in the tissues. I thought, well, what if that's happening in the bladder?
Absolutely, and it can be both, as in, because they are linked and connected, if you're not getting the blood flow there, it is harder to clear infections. Infections don't always show up, especially if they're embedded in the tissues. The tissues are poor, they're not getting the nutrients or the oxygen. And I do think it's a crying shame, and people don't actually realise how debilitating that is. I mean, I try to use humour to hide the pain that I'm in, but my God, it is 24/7.
I don't want to start a stampede or anything. We have cured interstitial cystitis in some patients. When we looked at all of our vein pain patients, and we used a survey, which is a validated survey for interstitial cystitis, it went like 65% of them had it, and maybe 35% of them didn't. Before and then after, those reversed. 65% of them didn't have it on this validated survey. Now, this is subjective, but this guy, not Dr. Nymark, he stumbled on the same thing, and what he did is he took young women who had pelvic pain in these veins, and he did urodynamics, and he did ultrasound, and he even used a laser device to measure blood flow in the wall of the bladder. He had a control group, and what he found was that blood flow in the wall of the bladder was reduced to about 1/3 in the patients who had the big veins. And then when he went down and embolized the veins with coils and got rid of the high venous pressure, kind of rerouted blood flow, he found that the velocity and the amount of blood flow in the microcirculation, the wall of the bladder, became normal. Wow.
Wow, indeed. My GP has referred me to a gynecologist for further investigation, but given the long wait times and research suggesting that many in the field may not be familiar with PVCS, I'm fortunate to be exploring a private assessment through the Whiteley Clinic to either confirm or rule out this condition. Like, subscribe, and stay tuned, because part 2 is coming soon.